Cool. So morning, guys. I'm just going to be doing a little bit of ENT today. I think I only have about 45 minutes or so I'll try and keep this as high yield as possible. If you have any questions, then my email's on there, so feel free to shoot me any questions after, or just chuck them in the chat now, and I'll try my best to answer them. So in terms of how I structured this presentation, I think ENT is a super vast topic. And like I said, it's pretty hard to get all of it done in 45 minutes alone. The main thing I took away from fourth year is that there are a whole heap of symptoms regarding ENT. And I feel that if you target your learning to these particular symptoms, rather than the diseases associated with them, you inevitably end up covering a lot of the content that they'll assess at the end of the year. So probably that's a nice way of going about it. And this is how I tried to kind of structure my presentation today as well. So I spoke about some of the conditions with each of these symptoms involved. So a couple of disclaimers. Obviously, this presentation is definitely not meant to be a textbook, but just a very high yield summary of the conditions that I thought were quite important when I was back in fourth year a couple of years ago. Most of the learning will hopefully be done through your structured GP lectures, as well as just being a GP practice, which hopefully won't be affected by COVID, and just chatting with other senior students as well. The investigation and management parts I've tried to make as OSCE focused as possible. So if any of these come up, hopefully you guys will be fine at the end of the year. And like I said, if you have any questions, just chuck me a message. So before we get started with the actual clinical side of things, I thought we'd do a quick refresher on the anatomy. So just taking you back to a little bit of pre-clin anatomy here, the ear has three main parts. So you've got the external part, the middle part, and finally the internal part. The external and the middle part are mainly concerned with transfer of sound, and the internal part is the one that's responsible for more balance and just sort of keeping you upright. In terms of the division between external and middle, we've got the tympanic membrane, and then what joins the middle to the inner ear and eventually the nasopharynx is the pharyngotympanic tube. And when you guys do an otoscopy examination of any patient this year, like even during pediatrics, you need to have a thorough examination of what the ear looks like outside. And these are just some of the structures you should be commenting on, which we'll talk about in just a little bit. In terms of the middle ear, it's not too important anatomically. However, there's a lot of stuff that goes on there clinically, with the main stuff being in an otoscopic examination. And you should be able to comment quite well on all of the structures you visualize during an otoscopic examination. So this would include things like the three auditory ossicles, the stapedius and tensor tympani muscles, the tympanic membrane itself, as well as if there's any associated inflammation there. So that's a very important thing, which will come about in a lot of the clinical conditions. In terms of the walls of the tympanic cavity, this is a slide that I directly ripped off a preclinical lecture. This isn't too important from a fourth year clinical medicine content, but I have seen questions on this occasionally come up in the VIA. I'm not sure if the VIA will be tested for you guys this year, like if it's an examination that's still happening, but I just thought I'd include this in just because there's a couple of vessels in the top and the bottom of the tympanic cavity that make it quite important to remember. I'm not sure if you guys have the VIA though this year, so if someone just wants to quickly.
No VIA.
Okay, no VIA, awesome. So maybe don't worry about this slide then too much, it's just more for the sake of completion. Internally, as we spoke about, this is primarily the part of the ear responsible for balance as well as the conduction of sound. So it consists of the cochlea, the vestibule, and the endolymphatic sac, and all of these are particularly relevant in someone who has vertigo, which we'll talk about in a second. With regards to the nose, there's not much going on there, as the main things that we're concerned about is either a nasal fracture, a blockage of the nose, or a bleeding nose. And in terms of the bleeding nose itself, the main thing to remember is that the bleeding primarily occurs from the front of the nose because a lot of the arterial supply rests there. So this is also known as the Kiesel black plexus, and it's primarily the main cause of being responsible for the bleeding and epistaxis. And the final part of the anatomy just focuses a little bit on the pharynx and the neck. So the pharynx has three main parts that we're concerned about. Again, don't worry too much about the innervation. This is just stuff that you kind of generally need to know about in a broad, in a sort of broad sense when studying fourth year clinical medicine. Sort of the main thing that comes up is with regards to danger spaces in the neck. So if we sort of talk about the neck overall, there are particular spaces within the fascia in the neck where stuff can collect, in particular either blood or pus. And the main thing to be concerned about is the so-called danger space, also known as the alar space. And the reason why this is particularly important is that a lot of the infection in this particular space can spread directly to the thorax. And therefore, what starts off as a localized infection ends up becoming quite systemic. Again, this kind of comes up in a few of the clinical conditions that we'll be talking about now. Okay, awesome. I thought we'd start off with a quick question. So we've got Jack, a 24-year-old, complaining of ear pain. Does anyone want to have a crack as to what's going on here? Maybe just chuck it in the chat or something. Okay, getting a couple of answers here. Getting a B, a C, an H. So there's quite a few answers here. Okay, so it looks like the most popular answer here has been B, which in this case is the right one. So Jack has acute otitis externa, or inflammation of the external auditory canal. So in terms of what otitis externa is, it's an inflammation of the external auditory canal. There are several causes that you guys need to know about from a GP perspective. The most common cause is often a bacterial one. So that includes Pseudomonas species, so Pseudomonas aeruginosa or Pseudomonas vulgaris. Sometimes Staph aureus can cause it, and sometimes even E. coli can cause it. But more often than not, it's the Pseudomonas species that's particularly responsible for causing the complications with it. Fungal causes are also quite common, in particular Aspergillus and Candida. A little bit of a buzzword that comes up in your fourth year exams is that if you have a Candida infection of the external canal, you often get a wet blotting paper debris. And if you have an Aspergillus infection, you often get black spores as well on the associated otoscopic examination. So for instance, if they give you a picture of something like this with black spores on it, that's meant to push you more towards a fungal picture. Dermatological causes are also quite common. In particular, autoimmune skin diseases such as psoriasis and dermatitis can compound otitis externa as well. As was seen in Jack's clinical case, this is a direct result of being exposed to hot and humid conditions. So most commonly, it's seen in swimmers and surfers. So it's another name for this condition is also known as swimmer's ear because it's very commonly seen in that particular demographic. Since it's primarily on the outside of the ear canal, you get a lot of itching at first. So people just sort of constantly flick around their ear and the external part of the ear canal. And you get quite a bit of pain when moving the auricle itself. And that's again because a lot of the pathology is localized to the outside of the ear. Because of the associated swimming and water retention in the demographic, you get a feeling of fullness in the ear canal and occasionally some discharge as well. And because of all of this accumulation, this can manifest as hearing loss. Edema is commonly seen as well as some lymphadenopathy. Lymphadenopathy is one of the most clinical signs in this particular condition, and never neglect to just feel around the glands in the neck and on the back of the ears when doing an otoscopic examination as well. You occasionally can get discharge, which we spoke about earlier, but the important thing to remember is that if you have offensive discharge, so really strong smelling or really bad looking discharge, this is an indication that there's an underlying bacterial infection. And most commonly, the type of bacteria causing this is a coliform bacteria, which is also known as a rod-shaped gram-negative non-spore forming bacteria. Bit of a mouthful there, but Monash really likes to have you keep that in the back of your mind from a clinical perspective. And we already spoke about the findings on an otoscopic examination. The other thing to remember is that because of all of this associated inflammation on the external canal, you get a little bit of dull erythema on the tympanic membrane as well. So it does appear a little bit angry and inflamed, but not as bad as otitis media, which we'll talk about in a second. So management for this one, the main thing to remember is that it's primarily pain relief. The people who present often come in with quite a lot of discomfort, and just addressing their pain addresses a lot of the concerns that they would have when first presenting to the general practice. So keeping it dry is also quite important because the primary cause of this is the hot, humid environment that we spoke about. So just keeping it away from water or anything else. So encouraging the patient to maybe not shower for a couple of days just to keep that area dry is also something that could be suggested as a lifestyle measure. One of the mainstays of treatment is something called an oral toilet, which is essentially a gentle suction and a dry mopping using cotton wool. And this is, again, can be done in the GP's office. Once we do all of this and we're satisfied that the area itself is quite dry, we can use a little bit of dressing, which is impregnated with steroid and antibiotics. So they take some gauze that's dipped into a mixture of steroid and antibiotic cream, and the GP just puts that in the ear for a little bit. kind of like that image shows. So in terms of more medical treatment, Sofradex is one of the gold standards of treatment for this particular condition. And Sofradex is the brand name for dexamethasone, pharmacin, and gramicidin drops. So it's essentially a combination of steroids and antibiotic drops. For more sort of fungal infections, Kenacome is another medication that can be used. And the antifungal in this is the first one, triamcinolone acetonide. Other treatment, as we mentioned, analgesia is the gold standard in this particular condition. So really making sure that the patient is comfortable and preventing sort of more things that can compound the actual symptoms. So in this particular context, if a child, for instance, develops otitis externa, you want to encourage and reassure the parents that the child shouldn't be scratching around the ear, putting stuff in, trying to flush all of that out, as that can just cause new problems. The overall symptoms should resolve within a week. So it's a relatively sort of quick turnaround time. And the main things we'd be concerned about is if the symptoms persist beyond a week. So when can otitis externa actually become something that we worry about as a GP and consider hospital admission? The main thing is with regards to the Pseudomonas infection, one of the causes of the bacterial otitis externa subtype. So in patients with Pseudomonas infection, if they're really unlucky, the otitis externa can spread into the base of the skull. And this commonly occurs in three patient demographics: in those who are immunocompromised, in those who are diabetics and consequently have some degree of immunocompromisation, and finally those who are elderly as well, just because a lot of the stuff there has just gotten mechanical wear and tear over time. Since this starts to erode the the base of the skull itself and involves cartilage and bone, this should be considered as an urgent referral. So a patient with suspected malignant or necrotizing otitis externa needs an urgent CT scan. And the purpose of this scan, or even an MRI scan, is just to see how much of the actual bone is being eroded. These people need urgent IV antibiotics. You can't really hold off and wait with oral antibiotics or temporizing measures. Without IV antibiotics, they're going to get very sick and are at a pretty high risk of passing away. So a very, very important condition and not something that should be neglected when assessing a patient with otitis externa. Awesome. Any questions on otitis externa at all? Sorry, I can't really see my chat, so I'll just quickly double check that there's nothing there. Okay, awesome. Cool. Let's move on to otitis media. So otitis media, like its name suggests, is an inflammation of the middle ear, and this is again associated with deep-seated ear pain, deafness, and other systemic illnesses. The sort of take-home message with otitis media, unlike otitis externa, is that this is extremely common in young children, and primarily this is due to the actual anatomy within children. So children have flatter eustachian tubes. As a result of the flatter eustachian tubes, there's less nasal drainage because since the tubes are not as vertical, all of that stuff isn't flowing down into the nasopharynx, and therefore a lot of the muck in children just sort of stays within the ear canal. And that muck often sort of just compounds over time and causes the infection in question. Since this is a direct result of the anatomy, again, it's very rare in adults. And if you suspect otitis media in an adult, you should kind of consider other diagnoses as well, just on the probability scale. So one of the main things to consider in an adult is cholesteatomas instead, because that's something that could be responsible for the presentation, which we'll talk about in a second. The sort of textbook presentation of otitis media is they come in complaining of blocked ears, as well as an associated pain and fever. More often than not, they can have some sort of gunk coming out of the ear as well. And this gunk is a direct result of the tympanic membrane being perforated due to the inflammation associated with it. And this is a beautiful example of what the tympanic membrane looks like. Very, very angry and inflamed. Causes, again, typically viral. So adenovirus and enterovirus are the big ones here. But bacterial causes include Haemophilus, Streptococcus, Catarrhalis, and beta hemolytic streptococci as well. In terms of signs and symptoms, we spoke a little bit about the constitutional symptoms being pain and fever, as well as some discharge from within the tympanic membrane. But other things to consider are actual redness of the tympanic membrane, which typically begins in the upper outer quadrant and spreads more peripherally and down the handle of the malleus. You also get a loss of the light reflex. So typically when you turn on an otoscope, when you shine a light into the tympanic membrane, you get a little bit of the reflection of light back into your eye. And this won't be seen as well in otitis media. And again, a direct reason for that is because of all of the fluid that's starting to accumulate there, secondary to the infection and inflammation. Bulging of the tympanic membrane is a late sign, so Monash really likes to focus on bulging of the tympanic membrane during their GP lectures, but it's important to realize that this is something that's not commonly seen unless the otitis media has been sort of left undiagnosed for a fairly long time, like at least a few days to a week. So it's something that's not commonly seen in the first stages of patients presenting with just ear pain and fevers. If you have blisters, this is a very, very strong indication that the underlying cause is viral and not bacterial, as blisters and sort of skin collections are not commonly seen with a bacterial infection. So the management of acute otitis media. This is a super, super important one and something that you guys in fifth year as in the emergency department, or even as an intern within the emergency department, or even in fourth year in a GP setting, will have to convince worried parents that antibiotics are not necessary for treatment. So this is a very sort of strong point that's been put forth by the RAC GP. Antibiotics should not be routinely prescribed for acute otitis media in children. And the main reason for that is what we spoke about earlier. The cause is often viral and not bacterial. So in terms of when antibiotics need to be started, antibiotics need to be started in very, very particular contexts. And those include the children being aged less than 6 months, if the pain is out of proportion to the clinical findings, if there's tympanic membrane perforation, if there's fever for greater than 2 days, if the child has become septic or toxic, if they're of Aboriginal or Torres Strait Islander origin, and the main antibiotic to consider at this point is just a simple penicillin like amoxicillin. So these 6 criteria for which antibiotics should be considered for commencement, please commit it to the back of your mind. This is something that commonly comes up on the written exam. And I think it's very fair game if it comes up in like an OSCE sort of explanation scenario in a GP setting as well, where you need to counsel a patient that their child doesn't need antibiotics for the ear infection. So as we said, the recommended antibiotic is amoxicillin. If they are allergic, you need to commence cefuroxime. So this is irrespective of the degree of allergy, cefuroxime is the next line in question. So again, like otitis externa, there's a couple of complications that need to be considered. These are the 3 most common ones that come up in a clinical setting. So the first one is tympanic membrane perforation. So this is relatively common and results in discharge. So you get a lot of otorrhea coming out because the tympanic membrane is no longer keeping all of the fluid collected back in. But you get quite a lot of relief of pain as well, because all of that fluid is now just having a beautiful way of coming out of the body. So the pressure inside the middle ear is now being significantly relieved all at once. And therefore, consequently, you get a relief of the pain as well. Remember that otorrhea due to tympanic membrane perforation should be distinguished from otitis externa, where the otorrhea is already on the outside of the ear canal. So you need to figure out, is the gunk coming from the middle ear leaking out, or is the gunk already on the outside and it's just sort of continuing to leak out? So a very sort of important clinical thing there. How do you do that? This can be ascertained to an otoscopic examination. So be very careful when you do this because the membrane is already perforated, but have a look inside the patient's ear, see what's going on there. And if clinically you suspect that they have an acute otitis media, then kind of push your sort of treatment and management plan towards that line of thinking. The second one is something called OME, or otitis media with effusion. So sometimes in a select group of patients, about 40% of people have persisting effusion more than 5 weeks after the original diagnosis of AOM. So if this is still something that's happening in the patient, you might need to consider a second dose of antibiotics, just because it's the patient's obviously not getting better. And if the effusion continues to persist after 3 months, that's when you really need to start worrying and maybe consider referral to a specialist and even a hearing assessment. From a more practical point of view, and I'm not sure how many of you guys have done a pediatrics rotation yet, children with chronic ear infections have really, really poor outcomes in terms of their learning and development. And this makes a lot of sense because if they have chronic ear infections, they are unable to hear, and consequently, they're unable to follow instructions and have normal development as compared to their peers. So as a result of that, these children fall quite behind in their gross motor, fine motor, like the whole sort of developmental areas. And as a result of that, they're at risk of just being left behind quite significantly later on in their life. So consequently, urgent ENT opinion and a hearing assessment by an audiologist should be immediately considered for this particular population. The last one, and a really big red flag, is something called acute mastoiditis. So acute mastoiditis has a very particular triad, which is pain, swelling, and tenderness behind the ear, which kind of looks like that. The children who come in look pretty toxic. They just don't look that well. They come into ED, they just don't want to be there. They don't want to talk to you. They just don't want anything to do with anyone touching them or examining them. And this is a really, really big red flag. Again, you don't want to wait for this, kind of like the necrotizing otitis externa, IV antibiotics immediately. And what you start them on is flucloxacillin, as well as a third generation cephalosporin. You don't want to wait around for these kids because they're at a pretty high risk of deteriorating very acutely. These kids, again, need an immediate referral to the ENT. And the management plan will be sort of determined by a specialist at this point. It's not something that can be managed entirely at a GP level, and there needs to be a multidisciplinary approach for this. Cool. The other sort of important thing that comes up with regards to ear infections is grommets. And grommets, there are a couple of indications from RAC-GP that Monash really likes you to know, and it's quite relevant for your learning as a future junior doctor as well. So some of the indications for grommets include recurrent otitis media, particularly of the bacterial subtype, persistent gluea, which is just a lot of effusion for greater than 10 weeks, as well as a bilateral conductive loss of greater than 30 decibels. So both sides are affected in this particular scenario. If you have a unilateral effusion, but it's greater than 6 months, that's another indication for grommets as well, and at-risk populations, like we kind of spoke about. So in these particular populations, those who have developmental delays, those who are born with sort of congenital anomalies, our threshold for grommets significantly drops. So you would consider grommets much quicker than, say, someone who doesn't have a developmental delay, for instance. Okay, the last condition that I really wanted to focus on was a cholesteatoma. How are we doing for time? I think we're doing okay for time. So a cholesteatoma is essentially an accumulation of squamous epithelium in the middle ear. And there's different kinds of cholesteatomas that you need to know about. So for instance, an attic perforation of the tympanic membrane contains such material, whereas a safe perforation does not. I think I forgot to include a table of this in my slides. I'll make sure to include it before I upload them. But the important thing to remember is that the presence of all of this epithelium within the ear canal causes erosion of the bones, in particular the temporal and the middle ear bones, as well as the tympanic membrane. All of this erosion has a pretty bad consequence, with the ultimate one being sensorineural hearing loss. And that's obviously something that we want to prevent as doctors. So in terms of the types of cholesteatomas, there's two main types that you need to know about. The first one is a congenital type, which is also defined as a small white pearl. So it kind of looks exactly like this otoscopic examination here, where this little bit here kind of resembles a pearl. And this is thought to be due to migration of the ectoderm. Don't really need to worry about the embryology. It's not something that will be tested in a clinical context. It's just something to consider that if it is a congenital cause, like you need to consider that other people in the patient's family might be having it as well. The second and far more common one is the acquired cause, which is a cholesteatoma developing after an otitis media event. So that's just something to consider in terms of the long-term management of the patient. On an otoscopic examination, you have white flakes inside the hole, which kind of look like that. The important thing to remember is that, again, you don't necessarily have to see these white flakes. This is a very textbook definition, especially if the patient has pretty waxy ears or scabby ears and there's other stuff blocking it. You don't necessarily have to have this sort of appearance. With the cholesteatoma, again, refer to a specialist. And the reason why you're referring to a specialist is that the only way this can be removed is surgically. You can't really flick this out within a GP practice. It just needs to be removed from within a surgical sort of management. So again, complications, you can get rupture, especially if this collection of skin goes into the eardrum, and this can cause infratemporal or intracranial complications because all of the bugs from the outside of the ear can now leak on the inside. So pretty bad event there. And the purpose of doing a surgical removal is to prevent that from happening. You don't want the rupture to happen. Okay, awesome. That kind of covers the big three that I really wanted to focus on from a hearing infection and like sort of ear pathology point of view. There are obviously quite a few more conditions. Historically, a lot of the questions have been targeted to these three conditions, which is why I really wanted to focus on them. But if you have any questions on anything else, just chuck me a message and we can, I'll see if there's any notes that I can email you guys after. Okay, awesome. So moving on to hearing loss. Another question here. So we've got a sort of middle-aged gentleman with a 3-month increasing history of tinnitus and some hearing loss on the right side. So what do you guys reckon is going on here? Okay, we've got a couple of mixes of answers. So we've got, let me just get the options. I can't see that here. We've got some presbycusis, which is hearing loss as a result of age. We've got some noise-induced hearing loss. We've got quite a few acoustic neuromas as well. So I'm a little bit of a mix here. Okay, so this one is an acoustic neuroma, and this is a very sort of textbook presentation of what an acoustic neuroma would look like. Okay, so in terms of causes of hearing loss, I personally felt that this wasn't that well taught in the GP lectures, and I actually got quite a bit out of it in the Murtaugh's textbook. So I think that's a really good resource for hearing loss because there's a very sort of physiological way that they've approached it in Murtaugh's, which I found quite useful, and it just helped me sort of understand it a bit better than just rote learning all of the conditions. So there's quite a few things that can cause hearing loss. When asked about hearing loss in like an OSCE setting or in a patient counseling setting, always remember the most common causes. So in terms of conductive hearing loss, the most common cause is having wax there. So this makes sense. You've got wax there. Wax is just blocking the conduction of sound, and therefore it's one of the causes of conductive hearing loss. Sensory neural hearing loss is a little bit different. So taking you back to, again, your preclinical examination here, if you guys remember the Weber's and the René's test, you got to remember that air conduction is better than bone conduction in certain types of hearing loss. And that's how you sort of judge what sort of hearing loss the patient has. Obviously, the gold standard of diagnosing hearing loss is through an audiogram, and I'll go through what that, through an audiology test, sorry, and I'll go through what the audiogram looks like on the next slide. But it's sort of important to remember the clinical examination aspect of this as well. So in terms of the causes that quite frequently come up in fourth year, so impacted wax, that's a nice and simple one. Noise-induced deafness, again, exposure to loud noises, particularly depending on your sort of vocation, like if you work as a air traffic controller or you work in the sort of entertainment industry where there's a lot of loud noises, these are things to consider as well. Other causes of the conductive hearing loss subtype include eustachian tube dysfunction, perforation of the tympanic membrane, cholesteatoma, and otosclerosis. So we've kind of covered these three earlier. Otosclerosis is a bit of a medical emergency in which we need to get management by an ENT surgeon, and management is just removal of the stapedius bone. So you do a stapediectomy. That cures about 90% of all cases of otosclerosis. The last 10%, unfortunately, there's not much that can really be done. The sort of take-home message from otosclerosis is that it's a genetic condition. I think from memory, it's an autosomal dominant condition. So whenever you see someone presenting with suspected otosclerosis, you need to do a really thorough family history for them. So it's kind of like taking you back to third year when someone comes in with PCKD or polycystic kidney disease, you need to ask them questions about like berry aneurysm, something that wouldn't normally connect at all to a kidney pathology. But since we're focusing on more the family sort of genetics aspect here, we need to consider the condition as a whole. And the same thing for otosclerosis as well. Sensory neural hearing loss, we spoke about noise-induced deafness. We've got presbycusis, which is just age-related hearing loss. Acoustic neuroma, which is what the previous patient had. Meniere's disease, a cause of vertigo, which we'll talk about in a second. Something called sudden sensory neural hearing loss, which is, again, another medical emergency and something that needs to be dealt with pretty immediately if you suspect it. And cholesteatoma, again, sorry, I've got a typo there, that should be in a ear. So cholesteatomas are a bit of a funny one because they can cause both conductive and sensory neural hearing loss. And the way the mechanism of action of either of these works is on what part of the ear canal is being eroded by the actual collection of epithelium. So if the ossicles are being eroded by the epithelium, it's more of a conductive picture. If the inner ear is being eroded by the epithelium, it becomes more of a sensory neural picture as you're kind of going all the way in. So just an important thing to consider with cholesteatomas, and another reason why surgical removal of cholesteatomas by ENT surgeons is that much more important, because you want to prevent this from happening. So one of the really important things that you guys will take away from GP, for those of you who haven't had a GP rotation yet, is knowing how to adequately describe and analyze an audiogram. So I don't have too detailed notes here, apart from just what a conductive and a sensorineural audiogram looks like, but definitely have a closer look at how to sort of analyze an audiogram, how they show which ear is left, which ear is right, and how they show what the sort of bone conduction is, because all of these things, sometimes if faculty is being really mean, they might give you an audiogram without the legend at the bottom, and you might just be expected to read it. And my GP supervisor in fourth year, who's one of the coordinators of the GP program, mentioned that quite a few years back, the faculty did do this. So they just wanted to see how well students could actually read audiograms. It sounds like a super mean thing to do, but I think it's something that if you have the time when you're learning, maybe commit the legend to the back of your brains as well. Okay, awesome. So that's pretty much everything for hearing loss. We'll move on to vertigo now. I think we're doing okay for time still, which is great. So another question here. Awesome. I think we're getting a couple of answers. I'll maybe give it another 20 or so seconds. Cool. Okay, we've got 100% response rate for this, and all of you guys went with B. So this one is classic BPPV. Couple of things in the picture that are meant to push you away from any of the other diagnoses in this particular stem. One of the big ones is the fact that there's no hearing loss. So BPPV presents purely with vertigo symptoms, and there's no sort of associated hearing loss or deafness or anything that might make you consider something a little bit more sinister. The other thing to remember with BPPV is that it starts off very, very innocuously and suddenly. So her symptoms began acutely. So the sort of buzzword that you guys might hear about is that BPPV has a so I've got that in the next slide here, but it's a seconds time course. So it comes on in just a matter of seconds, and it sort of sometimes self-resolves, sometimes depending on the crystals and depending on your positioning, can sort of persist for a little bit longer as well. Okay. So let's talk about vertigo. So one of the main things you guys would have learned in your neurosystems history was learning how to ask a person if they had vertigo. And I'm sure most of you guys would know the sort of question where like, do you feel dizzy or do you feel the world spinning around you? And I think that's a really good way of determining whether or not someone is just simply dizzy or whether they actually have vertigo. So in terms of what vertigo is, it's an illusion of movement of self or environment. And that's why we ask the patient, do you feel the world spinning around you? Because it's an illusion. It's not something that's actually happening directly around them. In terms of the different types of movements that the patient might be experiencing, movement may be either rotational, linear, or tilting. So more often than not, movement is just everything spinning around them. But sometimes in very sort of rare subtypes of vertigo, you might get more of a tilting movement of that the patient describes as well. Again, this is not too important for a clinical context. The important thing to sort of elucidate when you guys are taking a history is that, is the movement more of a dizzy one or is it more of a vertigo one? Other things to really sort of ascertain in more of a history picture is the vertigo central, which means does it originate from the brainstem or the cerebellum, or is it more peripheral, which means is it actually originating from the inner ear? And the way you do that is there's quite a few symptoms that differ between both peripheral and central vertigo. So I've gotten a little bit of a table here in which you can see some of the marked differences. So for instance, one of the big ones is nausea and vomiting. Nausea and vomiting is very, very rare in central or brainstem vertigo, but it's quite common in peripheral vertigo. So in someone with BPPV, they are going to be quite nauseous. And that's something that should push you more towards an inner ear problem than like a neurological issue. Nystagmus is another big one as well. So nystagmus in inner ear problems is typically very horizontal, whereas nystagmus in more sort of central or brainstem vertigo is more vertical. So when you ask a patient to jut their neck up and down, you can see their eye going vertically really quickly as well, whereas it's just very horizontal in a peripheral picture. The last one is compensation. So what that means is once you sort of go through nystagmus and you look at a patient's compensation with their pupils, it's quite rapid in peripheral vertigo because, again, there's no problem that's actually affecting pupillar compensation. Whereas in more sort of central brainstem disease, compensation can be quite slow. And that's, again, because a lot of the sort of ocular stuff is at the back of the head there as well. And if you have an underlying pathology with the central vertigo, if you have an underlying pathology within the central system causing vertigo, chances are you probably have an issue with compensation as well. Another thing that the compensation sort of refers to is how the compensation, like how the patient sort of reacts to the scenario. So, for instance, if a patient has BPPV, are they sort of able to steady themselves and keep themselves standing without really sort of moving around too much? Do they trip or anything like that? In someone with peripheral vertigo, they're sort of able to understand that something's clearly not right, and they're able to like, I guess, hold on to something, make sure that they don't have a fall, they don't hit their head anywhere. In someone with more sort of central vertigo, so especially in someone who's having a TIA or eventually a stroke, this compensation is really slow. So by the time they realize something is going on, it's far too late, and they probably would have already collapsed by then. So really sort of important to take a thorough history in someone presenting with vertigo. Okay, so hopefully that explains compensation a little bit better. Okay. So causes of vertigo are quite numerous, but in terms of when I say numerous, I mean that although there are quite a few things that cause vertigo, there are very few things that cause vertigo commonly. So the most common causes of vertigo that you guys will see in a GP practice and in an emergency department as a fifth year and a junior doctor are these four. And the way you differentiate them is their time course. So the most important question to ask someone presenting with vertigo is how long do these episodes last for? If they say seconds, it's most likely going to be BPPV. If they say seconds to minutes, it's going to be Meniere's disease. Minutes to hours, probably more of a migraine picture. And if it's a single episode, but it lasts several days at once, that's when you're suspecting more like a vestibular neuritis here. So again, in terms of how do you differentiate this clinically, on BPPV, you can do the Dix-Hallpike maneuver as a diagnostic test, or you could do the Epley maneuver as a management test as well. And both of them are reasonable. So what that means is if you do a Dix-Hallpike maneuver and you elicit nystagmus, you can be pretty convinced it's BPPV. If you do an Epley's maneuver and you relieve the actual symptoms that the patient's going because you've dislodged the crystals, that's again a pretty good sort of indication that, oh, it's probably BPPV that they would have had. Vestibular migraine is, again, like thinking back to your headaches from third year and how you manage them. The way you manage a migraine is you just sort of encourage them going to a quiet environment. So general migraine management would be removing the offending factor, which could be things like chocolate, coffee, drugs, anything that could actually cause the migraine to come on, and then just making sure they go to a dark and quiet environment where there's no stimulation and where they can just have a little bit of sensory deprivation to get rid of the migraine itself. Vestibular neuritis, as its name suggests, it's an itis, so you want to do something to control the inflammation here. And the thing that you give them is corticosteroids to control the inflammation and antiemetics to control the feelings of nausea that they might be having. So again, the corticosteroid you give them differs based on practice. I don't unfortunately remember the ETG guideline for this one, but I think from memory, it was just like prednisolone or something. So nothing too exotic. And the last one was Meniere's disease. So Meniere's disease is something in which you have, I think the cause is quite unknown. It's an inner ear disease in which you have collection of lymphatic fluid as well, so endolymphatic eye drops. And the gold standard treatment for this is low salt diets, low fluids. Sometimes hydrochlorothiazide might be trialed as well as a management option. And then Stemetil is something that's given as a treatment option for them. So Stemetil is a brand name. The drug name is prochlorpromazine or something. I think Stemetil, because of how commonly used it is, Stemetil is super reasonable to say in an OSCE, and they won't penalize you for that. Like they won't be like, you have to give us a trade name for this. The important thing to remember about Stemetil is that Stemetil is a symptomatic relief medication, which means that whilst you're giving the patient a lot of relief from their clinical presentation, you're not treating the underlying disease. So if the patient still continues to consume high salt diets and like a lot of like very sort of alcoholic and purine-rich food as well, the underlying pathophysiology is not being treated here. So the patient will still come back with more Meniere's disease in the future. So an important thing to consider there. Okay, so that's pretty much all of the stuff with regards to the ear that I wanted to speak about. I'll just wrap up with a little bit about the nose and throat now. So the first thing, then probably the most common presentation that you'll get with regards to the nose is rhinitis or hay fever. So rhinitis is defined as mucosal inflammation within the nasal cavity, and one of the biggest subtypes is allergic rhinitis, also known as hay fever. So this is inflammation of the nasal cavity occurring in response to foreign allergens such as pollen or dust, and it's an IgE-mediated hypersensitivity. So a couple of pathophysiology stuff there that I've seen come up in fourth-year exams in the past. So presentation, think about the time when like you've sniffed pepper or you've seen a friend have hay fever. They're just going to have really, really runny noses. There's going to be, they're going to sound quite nasally because all of that blockage is affecting their speech. There's going to be a lot of sneezing, which is pretty risky to do in the current climate with COVID and everything. And there's going to be itchiness as well. So quite a lot of pruritus there. The etiology of nasal cavity inflammation or rhinitis overlaps quite a lot with rhinosinusitis, which is when there's an inflammation of the sinuses around as well. So again, the most common cause is viral, and if a worried parent comes to you and starts asking you for antibiotics for their kid with rhinitis, you really need to go out of your way to counsel them and sort of acknowledge their worries, but let them know that it's not the gold standard of medication and it won't do anything to actually treat them. So very, very important roles for us as senior medical students and eventually junior doctors. Bacterial causes, the big ones are strep, Haemophilus, and Moraxella. So the same causes as pneumonia, and there's quite a bit of overlap there. And other causes could be allergies, which we spoke about, and immune disorders. So for instance, rhinosinusitis commonly occurs with like Wegener's granulomatosis or granulomatosis with polyangiitis. So just one of the weird sort of kidney conditions to consider, which can manifest with rhinosinusitis as well. Treatment for rhinitis, as its sort of presentation suggests, if it's occurring in relation to an allergy, just modify the environment around you. So for instance, minimize the exposure you're having to allergens, which include things like cleaning the house for dust mites, feathers, avoiding exposure to wool, pollen, things like that. Non-pharmacologically, before you start taking medications, saline nasal irrigation is the gold standard for this. So just getting a little bit of fess spray and then just doing a little 2 sprays into each nostril, which just sort of just clear all of the gunk there. Pharmacologically, this is when you can consider starting antihistamines. So again, there are quite a few antihistamines that you guys might be briefly familiar with. The broad ones that I remember off the top of my head are first generation and second generation. So first generation antihistamines are the ones that make you really drowsy. Second generations are the ones that don't make you as drowsy. So they're the ones that are typically preferred by the patient, because once you give someone a first generation antihistamines, a lot of lifestyle modification needs to be done. They're not going to be allowed to drive as much. They won't be allowed to go to work when they take the medication, things like that. If antihistamines are not working, you can consider moving on to decongestants, which is low-dose amphetamines. Again, not something that should be started without a prescription typically, so really sort of consider the reasons for you stepping up to starting them on like Sudafed or things like that. As we mentioned, antibiotics are not typically indicated for rhinosinusitis, but you can consider them when the symptoms are lasting greater than a week, if they're really, really, really sick, and if they have something called double sickening, which is essentially they get sick, they kind of seem to be getting better, and you're happy as a doctor, and then they get pretty sick again. And then you're like, oh, okay, clearly something's not going on right here, so I need to consider other options of what might be going on. In terms of the antibiotics you would consider, don't go for anything too exotic. Amoxicillin is the nice place to start here, so a simple penicillin. If they don't have a response to amoxicillin, you might want to consider adding a clavulanic acid here, so giving them Augmentin. And if they have hypersensitivity to either one of these, cefuroxime or doxycycline are very, very good sort of medications to consider as well. If someone has chronic rhinosinusitis, so they've had hay fever for a really long time and medications and all of the lifestyle stuff isn't really doing much for them, you want to consider referral to an ENT surgeon. And the reason for that is, firstly, they're going to do a CT scan to check how much crap your sinuses actually have. So if there's a lot of gunk and mucus there, the ENT surgeon might consider something called a FESS surgery or a functional endoscopic sinus surgery, in which they pretty much stick a nice long tube through your nose and they kind of remove all of the gunk from there. So flexible nasoendoscope is another thing that can be considered as well, just to sort of view everything there prior to doing the surgery. Okay, awesome. So the last thing I wanted to focus on is a little bit of the throat and neck stuff. So I'll finish off with pharyngitis and tonsillitis and a little bit of lumps in the neck as well. And I think we're going pretty well for time. So last question for the day. So we've got a 4-year-old girl coming with acute tonsillitis. What medication should she be started on? Ooh, okay. We've got quite a few responses for this one. Okay. So I think the majority of people are going with phenoxymethylpenicillin. There's a couple of flucloxes there. There's a couple of norfloxes there. Okay. So let's quickly go through this one. So this one is phenoxymethylpenicillin. So pharyngitis and tonsillitis are, again, pretty common presentations that you will be seeing in GP land. Pharyngitis, as its name suggests, is inflammation of the pharynx, and tonsillitis, inflammation of the tonsils. Pretty straightforward stuff there. The main thing to remember is that more often than not, the causes of both of these are almost typically viral. So about 90% of causes of pharyngitis and tonsillitis are viral, but about 10% are bacterial, and they're most commonly caused by group A streptococci. So these are the ones that are the big nasty bugs that we need to worry about. In terms of how you assess whether or not someone has a bacterial cause rather than a viral cause, you can use something called the Kentor criteria. And this looks at the following. So whether or not they have a cough, the presence of pus, particularly on the tonsils, the presence of lymphadenopathy, whether or not they've had any history of fever, and finally their age itself. So using the Kentor criteria, you can score whether or not the patient is having a bacterial or a viral episode, and then that can kind of guide your management there as well. So in terms of management of viral pharyngitis, we wouldn't really talk about that too much. But again, that's pretty symptomatic stuff. You're not going to give them any medication. Encourage things like hot tea, lemon and honey, things to just sort of relieve the throat. Strepsils could be a good option as well. So pretty straightforward lifestyle management stuff there. And again, simple sort of measures, but more practical stuff that often is forgotten in the heat of a GP setting is if they go to daycare, encourage them not to go to daycare, encourage them to kind of stay away from like other people in the house who might be sick so that they don't get even sicker, just things like that. For bacterial tonsillitis, there are different indications for it. So indications include presence of rheumatic heart disease, or if they're in a community with a high incidence of acute rheumatic fever. So rheumatic fever is something that really needs to be considered closely with bacterial tonsillitis. Scarlet fever is another big one as well, but again, I don't think that's as commonly seen as rheumatic fever in some communities. So just important to consider that. Antibiotic of choice, as we spoke about, is phenoxymethylpenicillin. In terms of the dose, which becomes pretty important this year, but again, don't worry about the dosage too much. It's 500 milligrams twice a day for 10 days. So a pretty hefty dose, a gram a day. If you suspect the patient might be non-adherent to oral therapy, like especially like a child or something who struggles to get the tablet in, you can consider giving them benpen IM injections. So that's just a single dose of benpen. Or you can, if they have an allergy to penicillins, you can consider cefalexin as well. If they have a really sort of immediate hypersensitivity, like an allergic reaction to penicillin, azithromycin can be started. You got to remember that particularly in more so the adult population who can really complain about pain being a concurrent cause, you have to consider paracetamol. But remember that in children who can't really talk about the symptoms that they're having, particularly in like babies, you need to consider that there's quite a bit of underlying pain there as well. So things like paracetamol or NSAIDs are super, super reasonable to commence at this point. If they have really, really severe symptoms, so like restricted swallowing, drooling, something that makes you think about oropharyngeal constriction, that's when you start steroids because you're worried that the infection is causing an inflammation so severe that they're not going to be able to get food and air in. And that's when you really got to start worrying about like, oh, okay, like I think this might get quite bad if I don't start them on some pretty big medication. Awesome. So the last slide was lumps of the neck, and this is just more of a spot diagnosis slide. So lumps of the neck, again, was something that I personally felt I was lacking in knowledge in fourth year just because it wasn't covered as well as I'd liked it to be. So what I did was I just looked at a couple of pictures from previous faculty slides and found these to be quite useful. So these are just some of the different ways neck lumps can present. So a thyroglossal cyst kind of has a very sort of distinct outpouching there. Thyroid nodule, a little bit bigger. Thyroid goiter, very similar to thyroid nodule, but important to consider in conjunction with the symptoms that they might be having. A parotid mass is a bit of a red flag because more often than not, a mass in the parotid often means an underlying malignancy. But parotiditis, just an inflammation of the parotid glands, as commonly seen in mumps, for instance, that's not something you need to worry about too much in terms of the actual lump, but more you worry about it from the clinical standpoint. So, for instance, mumps is highly contagious, especially if they're not vaccinated. So, really be careful about that. If say it's a parent who's developed mumps and there's an unimmunized child with them. So just sort of considering the whole situation holistically.